I'm going to talk to you about demystifying voice therapy. I'm Sarah Schneider at the UCSF Voice and Swallowing Center. I have no disclosures relevant to today's talk. So you see this person walks into your office. I'm going to show you two pictures. Before voice therapy and after voice therapy. Ooh, Do you wonder what happened in between the first picture and the last picture? Or do you just, what path would you choose? Would you, if you saw that patient in the first picture, I know I'm sitting in a room full of surgeons, would you take that lesion off? Would you zap it with a laser? Or would you send the person to voice therapy? Well, obviously I'm standing at the podium, so we're going to talk about voice therapy. Sorry. Some people think of voice therapy as a black box, where the person goes in with a broken voice, they go into this special room with the voice therapist, and then they come out and they are fixed. Well, there's a lot of things that happen in between that process, and really this is not the magic wand project. I wish it were that easy to wave the magic wand on the patient and then they were better. About 20 years ago in our field, there was not very much efficacy data around voice therapy. Even Joe Stempel, one of the fathers of our modern voice therapy, physiologic approach to voice therapy, stood at a podium last year and said, when I developed vocal function exercises, I basically made up how often you should do them. And it turns out, he said twice a day, turns out there's good efficacy for twice a day. But would it be better if it were 3 times a day? Would it be better if it were 4 times a day? We still don't know that information, but we're learning more. And we're working with our team to develop more outcomes-based research in this area. So voice therapy is putting together pieces of the puzzle. If you heard me talk a little bit about this earlier today. We look at the laryngeal exam, patient voice quality of life, vocal demand, and stimulability for change. In 2015, Jarrett Van Stan and colleagues developed this taxonomy of voice therapy, and I'm going to show you. Voice therapy is actually complicated. There are a lot of aspects going on in voice therapy, potentially all at once or maybe in succession. We are generally working on direct interventions, which you'll see sort of over here. And then we're also working on indirect interventions. You may hear about vocal hygiene, drink more water, don't talk as much. We try not to give patients a list of don't do's. We try to give them a list of things that they can do. And we really know there's more and more evidence to support that direct voice therapy, vocal exercises, talking in a more efficient voice actually promote healing of the vocal folds and expression of healing proteins. So the benefits of direct voice therapy, this is a picture of what might happen in something called a semi-occluded vocal tract exercise. Basically, we create back pressure at the lips, and then the exhalation of air and the movement of air through the vocal folds is offset by that back pressure. And so it squares off the vocal folds and it reduces the impact of vocal fold vibration. We can do that through airflow, working on rebalancing coordination of exhalation and vocal fold vibration. We can work on recalibrating resonance. We've all heard a hummingbird and that energy that comes from their wings. Well, we can shift where we're feeling our voice from maybe in the back of our throat to more of the front of our mouth. If we hum and feel resonance in the front of our mouth, that actually creates less impact of vocal fold vibration. The arytenoids, the vocal processes, do not close with as much impact when we create that voice. We also, in voice therapy, foster buy-in and motivation. This is not about me giving the patient exercises to do, it's really about them learning a new technique and how to make their voice. And that a lot of times starts with the physician who refers the patient for voice therapy. The way that we quote unquote sell the therapy is going to impact why the patient goes. If it is, you need to go to therapy, do these sessions, and then if it doesn't work, I'll operate on you. Versus, hey, if we know there's evidence to support that lesions can resolve with voice therapy, and so let's see how your lesions respond. Patients, even subtle shifts in the way we use that sort of language are going to make a difference in the patient's motivation to do what we ask them to do. So what happened for this gentleman whose vocal folds you saw at the beginning of these slides? Well, we did 5 sessions of voice therapy over 8 weeks. He practiced regular-ish at home. He did not do as much as I asked him to do, but he did practice pretty much every day, and he worked on implementing the techniques and building self-awareness to be able to reset his voice throughout the day to, like I was talking about, resetting posture to be more efficient. We worked on vocal hygiene and decision-making. We did a lot of counseling on how many students are you going to be teaching during the day? What can you do to balance vocal on and off time? Not go on voice rest and the lesion will resolve, but how can you balance things so you're not exacerbating the lesion and you're also practicing new techniques? Direct voice therapy included laryngeal massage and tongue stretches to reduce tension, postural adjustments, breathing, and then, of course, the most important part, getting the vocal folds to vibrate with less impact. So we did resonant voice therapy and conversational training therapy, CTT. And so that is what happened between this and this.